My name is Mike Robinson. For you, those of you that don't know me, I'm one of the third-year residents here. Today we'll be talking about retroperitoneal fibrosis. Today we'll just review kind of the main definition, the epidemiology, the pathogenesis, talk about the clinical manifestations and the evaluations of patients presenting with this, and review some of the current and medical and surgical strategies for this. We'll start with a case that came across Dr. Ng's desk. This was a 58-year-old female. She was in Paris on vacation in October and became anuric, presented to hospital there with a creatinine of 700. They did an ultrasound, showed bilateral hydro, and they were suspicious for RPF. They placed bilateral stents to decompress her and advised her to follow up back in Canada here. The rest of her medical history was really non-contributory, but notably they did exclude some secondary causes like medications like methotrexate, beta blockers. They ruled out infection and malignancy as well. So when she arrived in Canada about a month later, physical exam was essentially unremarkable. The plan at this point was to repeat her blood work and do a CT abdomen and a CT abdo-pelvis. Given her renal function, a non-contrast study was undertaken, and this demonstrates an iso-intense retroperitoneal mass that's difficult to appreciate, but is encasing the great vessels in the midline and as well the ureters. You can see the stents in cross-section there, and the mass itself was about 6 by 3 centimeters, extending from just inferior to the renal hilum to the common iliacs. This is again seen on a coronal section and demonstrates again the stent placement as well as some plaque in the aorta. And on sagittal imaging, you get an appreciation for the level of the disease, which is centering kind of around the L4 area. Her labs at presentation back in Canada showed a mild anemia. She had a slight elevation in her serum creatinine, and her sedimentation rate was within the normal limits. Discussion was undertaken with interventional radiology about whether biopsy would be appropriate in this circumstance, but given that contrast was felt to be precluded in her and that the risk of malignancy in her case was felt to be less than 10%, the biopsy was deferred. She began medical treatment with prednisone in December this just past December, and the plan is to taper this down over the next 2 months. The patient, however, had received some information along the line and was requesting definitive therapy with surgery. And the plans were made to continue with medical therapy and reassess her for this in the spring and follow her with monthly blood work and repeat imaging. The plan also was to change her stents, and we have a nice retrograde pilogram which demonstrates one of the classic findings being that of the medially deviated ureters. She's been decompressed for some time at this point, so we don't see the other findings of hydronephrosis or extrinsic compression as well. So it'll be interesting to see how she eventually turns out later this spring. Retroperitoneal fibrosis is a fibroinflammatory disorder occurring in the retroperitoneum that often encases and sometimes obstructs the retroperitoneal structures. It was first described by a French urologist, Albran, in 1905, but it wasn't until 1948 by an American urologist that it was defined as its own disease entity. This is where Ormond disease, the eponym, has come from, and you can see there's a list of other synonyms that it goes by. The incidence is considered to be relatively rare, less than 1 in 100,000. I've put an asterisk there because this figure is felt to be somewhat unreliable. Men tend to be affected more than women. There appears to be no ethnic predilection, no family clustering, aside from a few small case reports. Idiopathic disease makes up about 2/3 of the cases, whereas a secondary cause is seen in less than a third of cases. Most commonly, people present between 40 and 60 years of age, although exceptions at either end of the age spectrum have been reported. One such report comes from our own Dr. McLaughlin in 1979, who described this in an 11-year-old boy and reviewed 7 other children. This is a picture, I guess, circa 1979, and you know, we hear a lot about how tough our program was.
69.
69. Well, In any case, we hear a lot about how difficult our program was and how careful you had to be back in the day here, how tough it was.
I was in grade 12 when they published that.
You know what you didn't quote the original paper where Roger Saunders and I described the first description of retroperitoneal fibrosis on ultrasound.
On ultrasound.
That was in '69.
Well, this is Dr. McLaughlin from the head up around the time, and judging by how scared people were back in the day, I can only assume that he looked more like this
That's me
back
in
then.
grade 12.
Sure. Seen pictures of you in grade 12.
That's Andrew McNeely's body.
The disease typically centers, as we saw in the previous scan, around the L4, L5 vertebrae. It extends caudally down to the sacropromontory most often, sometimes extending along the iliac vessels. It can involve the renal hilum and often extends laterally over the psoas. Occasionally it'll spread outside of the retroperitoneum in 15% of people. It may extend as high as the mediastinum or as low as the common iliac bifurcation. The pathogenesis for idiopathic RPF is poorly understood, but there's two main theories. One is of local immune-mediated peri-aortitis, and the other is that this is a systemic manifestation of autoimmune disease. I'm trying not to spend too long on this, but in the immune-mediated theory, atherosclerotic plaque in the aorta gets presented to B and T cells with oxidized LDL and steroid by macrophages, and this basically spins an inflammatory reaction around the aorta and the local retroperitoneum through this local inflammatory reaction. This theory has some problems because patients often present with constitutional symptoms. They often show positive autoantibodies. They often have elevated acute phase reactants like ESR or CRP, and there's an association with a number of autoimmune conditions. I think these all underline that this may be more likely an effect of an autoimmune condition rather than an exaggerated local process. This is kind of a busy slide, but you know, it does demonstrate some of the associated fibrotic conditions here. The four highlighted in yellow share kind of a common etiology, it's felt, with retroperitoneal fibrosis, and if found together make up a more rare syndrome of multifocal fibrosclerosis. Fibrotic processes are found elsewhere in the body in up to 15% of patients, and there's a listed in white there of associated autoimmune conditions which occur of kind of an unknown frequency and may present either metachronously or synchronously with RPF. So the main point of this is basically just to underline again that there may be an autoimmune factor underlying all of this. There's a number of other proposed mechanisms, but I think the main point is that the pathogenesis of idiopathic RPF is poorly understood and is probably multifactorial. In terms of secondary causes, Campbell's in the newest edition presents a long table that classifies them in this manner. There's various other classifications that one can consider for secondary causes. We won't go through all of these today and just try to focus on the two main areas which historically have been drugs and malignancy. Probably most people are familiar with the ergot alkaloid category, which contains methosergide or Sansert, which historically has been used for migraine therapy. In the late 70s, this was reported in up to 12% of cases of RPF. It's been associated with fibrotic reactions elsewhere in the body, and it's felt that this may be mediated through a serotonin type mechanism. The other major category within the drugs is our dopamine agonists, such as methyl-dopa used in hypertension, pergolide, which has been used for Parkinson's disease, and some other important groups of medication include analgesics such as phenacetin or ASA, beta blockers I've highlighted here, and hydralazine, among others. Now, I've highlighted beta blockers here because historically the ergot alkaloids have been implicated, but in a more contemporary review by Shiel and Feely done from Johns Hopkins in 2009, they reviewed the presenting characteristics of those with RPF once malignancy had been ruled out. And they actually didn't find anybody with ergot alkaloid exposure in their group. They found 8% with beta blocker exposure, and more notably, they actually found that pelvic surgery or abdominal surgery radiation and asbestos exposure were much more represented in their group of 48 people. So I think it may show that the trends for secondary causes may be changing.
Mike, do you think that's just because so many people are on beta blockers and it just was an incidental finding?
It could be, and whether or not people are more aware of. I don't know how often methotrexate is used in migraine treatment anymore, so it may be a combination of both diminishing use in that class of medication and increasing beta blocker use, I think, since the 70s for sure. Malignancy is the other main category that should be considered, and this is felt to be mediated through a desmoplastic response to the retroperitoneal malignancy. This can be primary, such as with Hodgkin's lymphoma, non-Hodgkin's, or sarcoma. Common secondary causes would be prostate, breast, and colon cancer. And carcinoid tumors can act remotely through a serotonin-mediated mechanism, it's felt, and also through the generation of pro-fibrogenic growth factors. When a patient presents, typically the symptoms and the signs are usually nonspecific and don't lend themselves to the diagnosis of RPF very easily. The local symptoms tend to reflect the state of the disease or the organs involved, and the symptoms are typically grouped either as local or systemic. Local owing to the mechanical features and compressive nature of the mass, and systemic symptoms owing to the inflammatory nature. Pain is the most common symptom which patients present with, and it's been reported in up to 90%. They often describe this as in a girdle-like distribution. It's dull, it's constant, it has no increasing or relieving factors. It's often helped more with NSAIDs than opiates, again underlying maybe an inflammatory component. It may increase along with the disease, and it isn't until it involves the ureter that it really becomes kind of colicky in nature. Systemic symptoms such as fever, anorexia, weight loss are the second most common group of symptoms that are seen in patients. And then you can see in the local column there that there are other symptoms and signs listed that one can easily link to the structures that would be involved with an encasing or obstructing mass effect. Ureteral obstruction is present in 60 to 80% and typically occurs at the level of the common iliac vessels. The disease often presents bilaterally, and subsequent acute or chronic renal failure is quite a common presentation for patients who come in with uremia or oligonuria. The laboratory findings, again, don't lend themselves easily to diagnosis and aren't very good at differentiating primary from secondary causes, but one may see elevated acute phase reactants, and up to 100% has been reported. The positive autoantibodies, such as anti-nuclear antibodies, things like that may be positive. Patients are often azotemic and may demonstrate a chronic mild anemia, either due to renal impairment or just a chronic inflammatory state. If one's looking for malignancy, as one should during the investigation, one may see hypercalcemia. There may be positive tumor markers if you're led to perform those with your investigation. There may be positive fecal occult blood. The diagnosis of RPF primarily focuses or centers on radiologic investigation, and there's a number of investigations one can perform. Again, these lack the power to discern primary from secondary causes, but this is the primary method of diagnosis. Ultrasound is typically the first-line investigation done in patients who are presenting with renal impairment. This will demonstrate, as seen in the diagram, a hypoechoic periaortic mass, which is between the arrows there, and there may be associated hydronephrosis. Of course, the exam can be limited by a number of factors, including obesity, bony structures, and bowel gas. And again, I have to pay homage to Dr. McLaughlin here. In his 1970, no funny pictures here though, Dr. McLaughlin. In his 1977 paper, which investigated the sonographic appearance of retroperitoneal fibrosis, and he actually continues to use ultrasound, and I'm not sure how many residents he's probed with his new machine yet, but it's getting up there.
I was in grade 10.
Sorry, who was P. Walsh, please?
Who's that guy, P.C. Walsh?
A junior resident.
No, never heard of him.
Junior resident.
So the modality of choice really is contrast-enhanced CT, although as we saw with our case earlier, non-contrast studies can be used if this is indicated by the renal function. The findings generally will show a homogeneous plaque encasing the retroperitoneal structures. There will be a similar attenuation to muscle, and there will be evidence of contrast enhancement. The other thing about CT that's handy is that it can define the extent of the fibrosis. It can evaluate for associated lymphadenopathy and also for malignant causes. Interestingly, with malignant RPF, there's been some evidence that the ureters are displaced more laterally rather than medially, and that it actually moves the anterior anteriorly. This slide shows some of the contrast-enhanced CT findings with soft tissue mass encasing the aorta here, and on the left-hand side you can see that there's associated hydronephrosis. On the diagram or the CT image on the right, you can see that this mass is encasing the common iliac vessels. MRI has been felt to be comparable to CT, but of course is limited by cost and availability. It really has advantages in terms of no need for iodinated contrast, no need for radiation, and does have superior soft tissue resolution. In addition, the use of gadolinium has been shown to be useful for monitoring disease activity, although it should be used with caution in those with renal impairment. In addition, it's also been suggested that a heterogeneous signal on T2 imaging may point one more towards a malignant underlying process. So on T1 weighted images, we see that the signal is of low intensity, hypointense to muscle, and on T2 it can be variable. During the acute phase, when there's more edema and water content, the T2 signal seems to be stronger, and on the mature phase it is more diminished. And the arrows on the right-hand side are highlighting the ureters here, and this is actually a good slide to consider the challenges that one might face in getting a needle image guided into the area in order to biopsy this with the absence of contrast and all those big blood vessels around. PET scanning has also been used more to evaluate the extent of disease and assess for relapse. It's also been used to assess for treatment response, but the downside is that it has low specificity and is quite expensive. This diagram demonstrates the finding of RPF at the level we would expect, and also mediastinal fibrosis at the arrow on top there. IVP is becoming more of a historic investigation now, as contraindicated in renal failure, but does show the classic triad of proximal hydronephrosis, medial deviation of the ureters, and extrinsic compression. However, these findings can be mimicked by other disease states, so it lacks specificity. Retrograde and antegrade pyelography is done quite often at the time of nephrostomy tube or stent insertion, demonstrates a similar triad as IVP, and is useful for assessing the extent and involvement of the ureters. So once you've done your clinical investigation and your imaging, you usually have a diagnosis, and really that's all that's left to rule out are kind of this list of retroperitoneal fibroinflammatory disorders, which is kind of most people shouldn't recognize, and some of them are difficult to pronounce. The main one to rule out of this list would be a retroperitoneal lymphoma, and then if one really wants to discern between these, an RPF biopsy has to be undertaken, because it's only with immunohistochemical and histopathologic techniques that one can reliably distinguish between this differential. There's just too much overlying common features in terms of radiographic appearances of these. The role for biopsy is not fully agreed upon. There's no accepted guidelines. The main idea, to reinforce again, is that this is to rule out the any possible malignancy, and really you're unable to do so any other way. Strong indications, therefore, would be an atypically located mass, if there's a concern for malignancy during the workup, if the patient has a poor response to initial therapy, or at the time of ureterolysis, in the example of failed endoscopic management for decompression, frozen sections should be sent to rule out malignancy. Biopsy can be, biopsy can be done in one of two ways. Image-guided biopsy is the preferred method with CT guidance. It can also be done with MRI or ultrasound. It should be done with a core sample, such as using a true cut needle rather than fine needle aspirate. And there is the risk of sampling error given the amount of tissue that you're sampling. Surgical biopsy provides advantages in terms of this, but is more morbid unless the person's already undergoing the procedure, and really should be done if there's an inconclusive core biopsy and one wants a definitive diagnosis. On histopathology, grossly, one will see a white, tan, hard. It's been described as a woody plaque. Really, the gross features don't allow one to differentiate primary from secondary. The findings on biopsy may reflect the area of sample and the phase of disease. At the early part of the disease or the margins, there may be a more inflammatory component, and in the late disease or central portions, one sees more of a fibrotic component. This upper image demonstrates the dense kind of collagen deposition that occurs, and the lower image demonstrates the inflammatory infiltrate that presents in a nodular and diffuse pattern on microscopy. And probably from the urologist perspective, the most interesting thing to see on the path report would be not cancer rather than all the other list here. The basic principles for management are to relieve obstruction, to halt the progression of fibrosis, prevent recurrence, and interrupt the acute phase reaction and systemic manifestations of the disease. Initially, for patients who present with hydronephrosis or uremia, urgent decompression is warranted. Stents are preferred if possible due to associated improved quality of life, and you can get retrograde studies at the time. However, if the patient's critically ill, consideration should be given to nephrostomy tubes. Following decompression, the patient will require close monitoring for post-obstructive diuresis and judicial replacement of fluid and electrolytes. Renal function should also be monitored in this setting. In the case of secondary retroperitoneal fibrosis, the primary idea is to treat the underlying cause if this is reversible, such as removing a medication. And if this is the case, you should see a response within kind of 6 to 8 weeks. Glucocorticoids should be considered if there are severe manifestations of the disease or if there's no improvement on follow-up imaging within 3 to 4 months. Surgery would also be indicated if systemic therapy is not indicated, or if it proves to be ineffective, or again, if endoscopic management to decompress is unsuccessful. The treatment for idiopathic retroperitoneal fibrosis has changed considerably in kind of the last 10 years or so. It's now basically centered on medical therapy as the first line, and this is really based on the perceptions of medical therapy having a good response, increased morbidity, and associated with ureterolysis, and the accuracy of guided biopsies and increasingly sensitive imaging. It's worth noting that there's no randomized control trial comparing the two, but this is mostly based on the perception described. Of medical management, glucocorticoids are really the pillar of therapy and really have been established as primary treatment for IRPF now. It's often used alone with no additional treatment needed. There's no consensus that exists presently in terms of optimal dose or duration, and no adequate predictors for response in these people. And again, the mechanism for their success relates back to addressing some of the inflammatory underlying mechanisms that are felt to be implicated in this disease. Most of the evidence comes from small case series, but if one looks at the 3 largest studies using prednisone as a monotherapy, they were seen to have a greater than 90% rate of remission with a relapse rate of 11 to 25%. And this is over a follow-up period in 3 of these studies, well, one of the 3 studies up to 10 years. The doses were typically between 30 and 60 milligrams of prednisone that were tapered down, sometimes up to 2 years. And response is typically assessed on the basis of pain and constitutional symptoms, the size of the retroperitoneal mass, and as well monitoring renal function and acute phase reactants. Probably the best evidence to date for glucocorticoids as primary therapy comes from Vaglio and colleagues in his recent paper published in 2011. This is a group in Parma, Italy. Vaglio is seems to be one of the big hitters in the field of RPF. They took 52 patients who presented to their center between 2000 and 2006. They excluded secondary diagnoses, malignancy, medication review, and actually did biopsy in over half of their patients. And they started these 39 that were felt to have a new diagnosis of idiopathic RPF on kind of a high-dose induction prednisone treatment regime, which is 1 milligram per kilogram per day, with a max of 80 milligrams per day. They then assessed for remission within 1 month, and this remission was felt to be defined as either relief of their symptoms that they presented with, or a normalization of their acute phase reactants. Those who were considered to be in remission, which 36 of the 39 were considered to meet that definition, were then randomized to one of two arms, one being a tapering dose of prednisone over an additional 8 months of therapy, or tamoxifen over an additional 8 months of therapy. And their primary endpoint for the study was relapse rate at 8 months. Relapse in their study was defined as a recurrence of their symptoms, hydronephrosis, or an increase in the size of the mass by greater than 20%. In the prednisone group, you can see 1 of 18 patients relapsed. In the tamoxifen group, 7 of 18 relapsed. And of these seven, 5 of them were switched over to the prednisone arm, and those 5 went into remission. This is their Kaplan-Meier estimate of the probability at 26 months, to which point 26 months relapse rate was a secondary endpoint for them, and they used this estimate to say that the probability for relapse after 8 months of therapy within the prednisone group would be 17% compared to 50% in the group that took tamoxifen as kind of a therapy. And their conclusion from this study was that for the use of initiating and maintaining remission, that prednisone was better than tamoxifen, and they do have an impressive number initially that responded to initial high-dose steroids. Their results at the end of the paper highlight, or rather don't highlight, the fact that in some of these patients who had long follow-up, usually over a mean follow-up more than 55 months, that the relapse rate, recurrence rate for actually both groups was fairly similar. The prednisone group was 29% over that period, and the tamoxifen group was actually 36%. So overall, in long-term follow-up, they say that medical therapy we still have some work to do in terms of finding an ideal, durable therapy, but that in the short term, steroids certainly seem to be more effective. For those patients who do fail to respond when you start your medical treatment, there's really no defined period for what treatment failure is, but this should be reassessed in about 4 to 6 weeks after starting therapy. And if the diagnosis is in doubt, one should definitely consider biopsy and CT to confirm the diagnosis. If you confirm your diagnosis, you can consider starting high-dose steroids again. You can add an additional medical therapy, which we'll talk about, or you can consider this an indication for surgery. The main thing is that you don't want to miss a lymphoma or an infection, which is why you need to reassess your diagnosis in this case. Immunosuppressive agents are the other main class of medications, and methotrexate has gained a lot of ground recently because of its use in some of the other immunologic diseases and has a good track record there. MMF or Cellcept has also recently come into vogue in the recent literature owing to some small case series which show in combination with steroids it achieves close to 90% response rate as well. And the idea with these agents is really to use them in combination with steroids to decrease the dose of steroids, the duration of treatment, and limit some of the steroid-associated side effects. But it should be kept in mind that these agents aren't without their own toxic side effects themselves, and need to be used cautiously in patients who are elderly or have impaired renal function. Tamoxifen is kind of the last medication that we'll talk about, and it's a non-steroidal anti-estrogen. It is felt to act through an estrogen-independent pathway and has shown good effect in regression of desmoid tumors, which again share the fibroinflammatory basis that RPF has. It's been shown as a monotherapy to achieve a 74% response rate in one such trial, and given the recent study that's come out from Vaglio and his colleagues that we just talked about, One may consider reserving its use for patients who either have a contraindication to steroids, such as diabetes, osteoporosis, ulcer disease, or using it to, like we said with the immunosuppressive agents, use it as a steroid-sparing agent to minimize the dose and duration of steroid treatment. The good stuff now. Surgery typically has a reserved use now for indications such as failed endoscopic management, to obtain a definitive diagnosis of malignancy if you've had a failed cord biopsy, or if medical therapy has failed. The main disadvantages of surgery is that it has no effect on systemic manifestations and has been noted to have recurrence in up to half of those who just undergo surgery alone. The process for open ureterolysis involves placing ureteral stents prior to the procedure in order to facilitate identification and assist dissection. A midline transperitoneal incision is made, and one should consider doing bilateral ureterolysis, even in the case of unilateral disease, given that the disease often progresses to involve both ureters. The colon is mobilized medially, and deep biopsies should be taken and sent for both frozen and permanent sections. The ureter is typically dissected from the distal non-dilated section proximally to normal tissue. And usually it's not a problem to free up the ureter, as this isn't an invasive process, it's just an encasing fibrous process. But if due to traumatic handling or encasement of the ureter, a section of ureter needs to be removed, then there's a number of methods here that have been reported in the literature to manage this, such as UU, SOSH, Bore flap, autotransplantation, and even in rare cases nephrectomy, or in extreme cases nephrectomy can be used as the last resort. Regardless of how one frees up the ureter should be protected following ureterolysis. This can be done one of three ways. It has been reported that you can do a lateral displacement and just sew the peritoneum to the psoas behind the ureter. You can actually bring the ureter out of the peritoneum and close the peritoneum behind. But the preferred method for protecting the ureter is performing an omental wrap, which offers the most protection and also provides some blood supply to prevent late ischemic changes. And this is a diagram from Hinman's which shows how to do this. The colon is being retracted medially, and you can see the ureter at the top of the diagram. You essentially divide the omentum in its midline, ligating smaller vessels as you come through, ligating the gastroepiploic arch. The small gastric vessels are ligated as well, and the curtains of the omentum are basically taken laterally to be maintained on their pedicle of the gastroepiploic vessels, and then it's brought around the ureter and tacked down intraperitoneally. Laparoscopic ureterolysis was first reported by Cavusi and his group in 1992, and more recently Alashri in 1996 compared the use of open versus laparoscopic ureterolysis. They concluded that laparoscopic ureterolysis was less morbid and associated with all the advantages of minimally invasive surgery. They reported a 15% conversion rate and found that they were equally effective at 26 months for relieving the obstruction. They did provide the caveat that this may be technically challenging given the nature of the disease, however. Even more recently, Srinivasan and his group published in 2008 their experience with 70 patients with RPF. These were all comers. This was a two-surgeon study, one doing open, one doing laparoscopic, and it was out of New York that they did this. Yeah, it's quite a big number of patients, actually, and it was recruited over a 10-year period. So you can see 34 were done laparoscopically, 36 were done open. There was just over a 17% conversion rate, and they actually didn't find any significant differences in terms of some of the perioperative outcomes they were looking at, like OR time, complication rate, obstruction-free rate, estimated blood loss, transfusion rate, or length of stay. It was only in the subgroup analysis of those patients who were found to have idiopathic RPF that they found differences in terms of reduced transfusion rate and length of stay. And there actually seemed to be quite big differences that they found there, and really wasn't elaborated on why they felt that these differences were seen in the idiopathic group alone. And in addition, interestingly, they don't have any long-term follow-up, so we don't know the durability of open versus laparoscopic approaches in their study. But their conclusion was that open and laparoscopic approaches are comparable and must be determined based on a surgeon-by-surgeon, case-by-case basis. Postoperatively, one must consider that ureteral stricture may be a complication. Stents are usually left for 6 to 8 weeks following a procedure. One must also consider disease recurrence, and in the early 80s, the only evidence that I can see for the use of steroids was published, and this showed that if steroids were used postoperatively, there was a 10% recurrence versus 48% recurrence rate in those receiving surgery. And importantly, long-term follow-up, which can be done with imaging, lab work, and symptom monitoring, is warranted in these patients as disease recurrence has been reported up to 9 years following presentation or following initial therapy. So the take-home points really are that this is an uncommon, incompletely understood, but treatable condition. It's often a challenge to diagnose, and patients often present late in their disease. You must exclude important causes, most importantly probably retroperitoneal lymphomas. Steroids now are considered to be the primary treatment, and that long-term surveillance is warranted. So I'd like to thank Dr. Gourlay for his help with this, and also Dr. Ring for providing that interesting case at the beginning, and if there's any questions, can take those.